This week, we'll be discussing mental illness. So some quick definitions. When we define any mental illness, it is any mental, behavioral, or emotional disorder. So 1 in 5 U.S. Americans will experience mental illness within 1 year. So within the past year, 1 in 5 U.S. Americans experience mental illness. And roughly 1 in 4 Americans will experience mental illness across their lifetime. So if you think about the whole time you've been alive, if you think of 3 friends of yours, more than likely 1 between you and 3 of your friends will experience mental illness at some point in time. Any mental illness can range from having no impairment to being very severe in impairment. So situations that are very severely impair your functioning would be classified as a serious mental illness. So this is a mental, behavioral, or emotional disorder that results in serious functional impairment and substantially interferes with at least one major life activity. And 1 in 25 Americans within the past year have a serious mental illness. So the most common serious mental illnesses include the different spectrums on the schizophrenia spectrum, serious depressive disorder or serious bipolar disorder, but there are certainly others that fit within this category. The main thing is it has to substantially limit one of your major life activities. So if you have a mental illness that prevents you from working, going to school, leaving the house, this would be classified as a serious mental illness. However, there are lots of individuals who have who are highly functional living with mental illness. So you don't see it. They're going about their daily activities. That would be individuals who have less impairment resulting from their mental illness. So when we think about who is receiving mental health treatment, most of the bulk of the services are being provided to individuals with serious mental illness. So when we think about some of the treatments that we'll be discussing in policies, most of those are directed at serious mental illness. So if you think about the idea in marketing, there's an idea of this 80-20 rule. So 80% of sales are provided by 20% of clients or customers. Similar in mental illness treatment. So if you're a mental health provider, 80% of your time will be devoted to 20% of individuals. So people with serious mental illness specifically. So most of your time is going to be spent helping individuals who are really having some impairments in their life and would be classified within the category of serious mental illness. And that is at least how our mental health system is set up today. So we don't have as many preventative treatments, which we'll discuss. Most of it is people receive services when they are in really serious need of assistance. So prevalence of mental illness, anxiety disorders are the most common. So there's different types of anxiety disorders. There's generalized anxiety disorders with individuals who are kind of anxious about a variety of activities in their life. And then there's what's called specific phobias. So social anxiety disorder would be a specific phobia if individuals are scared of social settings, or if individuals are scared of heights, claustrophobia. I'm sure we've heard about different phobias. So these are very specific isolated incidents. So anxiety disorders are the most common. Then there's depression, which is 7% of individuals, PTSD, 4%, and so forth. And you can look at the rest. So one of the videos for class this week will be to learn a little background on each of these different types of mental illnesses. So if we look at the history of mental illness and the history of how treatment has been provided, specifically in the United States, we're going to go through each of these time periods. The first, if we think about pre-institutionalization. So institutionalization is when individuals were in state psychiatric hospitals. So before that, in early times, mental illness was really viewed as either religious punishment or demonic possession. So religious punishment, that some individuals, if they had major behavioral problems and mental illness, they were viewed as, oh, you must have done something wrong to deserve this, or your parents did something wrong and now their children are being punished. So this is religious punishment, that some sort of higher being was punishing you or your family for a wrong behavior in the past. There's also this idea of demonic possession, that you were possessed by a demon, and they did different practices to kind of get the demon out of you. If you've ever seen the movie The Exorcist, they did exorcisms to try to pull that demon out of you. When in reality, if we rewatch The Exorcist and think of that child as having a severe mental illness, we would obviously be providing different treatment than was provided in the exorcism. The thing about pre-institutionalization is there really was not any treatment options. They were typically cared for by family members or in almshouses. They were, so if they were living on the streets, begging for assistance, it was really, the care was provided on the local level. So if we think about the Elizabethan Poor Laws, where care had to come first from the family or from local governments, this is really the period that we're in. So they didn't have government assistance for people with mental illness. They would more than likely fall within that idea of the undeserving poor, because if they have a mental illness, you can't physically see what's wrong with them. They don't have a physical disability. They might very well be impaired and not be able to work or carry out daily activities of self-care, but they wouldn't be receiving assistance because they might be being viewed as a moral issue that, again, they did something wrong. That began to change in the 1840s with institutionalization. So there were a number of individuals, social workers, other caring individuals who kind of saw that individuals with mental illness needed treatment. They needed professional treatment, and they weren't really living at home, living on the streets was not in their best interest or society's best interest. So this is when state psychiatric hospitals started to be built. So these were typically built in like rural areas, and they would house large numbers of people. But the emphasis here is that this is the first time that professionals are really starting to provide treatment. So there are professional staff who work at state psychiatric hospitals. However, these were frequently characterized by poor living conditions, large numbers of people. Some of them were, using restraints, chained to walls. There were very limited staff options. So the staff received some training, but not a ton of training. And they used various, what some people would classify as inhumane techniques to provide treatment to individuals. They did, cold water baths, throwing water on people. They did lobotomies, because there wasn't a lot of knowledge on where mental illness was coming from and kind of the best way to treat it. But this is the first period that professionals are providing assistance for mental illness. In the 1950s, this is the first time that antipsychotics were developed. So antipsychotics is medication to help stabilize mood. They're mood stabilizers, such as lithium. So lithium is used for individuals who have some mood disorders, such as bipolar disorder, to help stabilize them. So if someone's having a major aggressive behavior, they're acting out, antipsychotics help to stabilize them. Of course, the thing to keep in mind, there are always side effects of antipsychotics. So if we think of these really strong mood stabilizers, there's some side effects such as weight gain, fatigue, insomnia. Some people feel like individuals with mental illness, if they're provided with a lot of antipsychotics, it kind of gets rid of their personality. They're just kind of walking zombies. And a lot of times, especially when these were first developed, these were used to just kind of stabilize them. So it makes it so that they're able to kind of keep moving without having any choice behavior problems. So what ended up happening is that these are being used to sedate individuals, they stabilize them, and then they can release them back into the community. The problem, if we think about antipsychotics in general, is that so individuals were given a few antipsychotics and then kind of sent back home. So that started happening in the 1950s because there were waiting lists for the state psychiatric hospitals, so people didn't have to stay there. But what ended up happening is that they ended up going back home and continuing to have those behavioral problems because there's really a large lack of medication adherence without professional support. So that someone reminding you to take your antipsychotic, every 12 hours, you might not remember to do it. Or because you're not in a bad state of mind, you might choose not to take it. Because you don't want to kind of have to continually take these medications that kind of make you a robot or a zombie. The other thing to keep in mind with antipsychotics in general is that they are most effective in conjunction with counseling, such as cognitive behavioral therapy. So if we're only using antipsychotics or medication to treat mental illness, that's not the most effective method. That this needs to kind of be combined with some sort of therapy. So just in general, that development of the antipsychotics in the 1950s led to a period of time called deinstitutionalization. Deinstitutionalization. So D means to remove. So this is the process of removing individuals from institutions. So around this time, there were some major profile cases of individuals in institutions who were being treated quite inhumanely. You're gonna watch a short video on what kind of was happening in institutions, and individuals didn't like it. They were separated from their family because the institutions were frequently in rural locations because that's where there was room to build a psychiatric hospital. So they were far away from their family, locked up, and it was hard for them to leave. So because of these inhumane conditions, there was a push to move people back to their communities, to kind of move people from these psychiatric hospitals back to their communities. And they were able to do that because of the introduction of antipsychotics. So because they had developed antipsychotics, they had the ability to stabilize individuals and move them back home. It was also less money. So, state psychiatric hospitals were very costly to run. So as state budgets weren't able to keep up with the state psychiatric hospitals, they had to push to kind of move out as many individuals as possible so that they could save money. So to continue the process of deinstitutionalization, the U.S. federal government passed what's called the Community Mental Health Centers Act of 1963. And this was passed to provide local communities with funding to provide outpatient mental health treatment. So this is the idea that people are best served at home. People are going to receive better services when they can go receive mental health and live at home rather than having to live in psychiatric hospitals with a bunch of other individuals with mental illness. So people will have better lives if they're at home and being provided care close to where they're already living. So what this act provided, or the goal of the act, was to provide funding. So the federal government gives funding to states, and then states will establish local mental health centers. And the local mental health centers offer community-based outpatient services to patients. So patients live at home and they receive services such as counseling, therapy, psychosocial rehabilitation. So there might be different groups on teaching individuals with mental illness how to do different jobs, how to appropriately socialize with other individuals. They offer case management to connect people with mental illness with a variety of services. They might have attendant care so that individuals with mental illness might need someone helping them with functioning daily and other services. So again, the goal of this act is to provide funding to local governments to provide community mental health services. This was passed in 1963 by President John F. Kennedy. So JFK passed this, and he was a very strong advocate for mental illness and for mental health treatment because he actually had a sister who struggled with mental illness. So the Kennedy family as a whole still is very active in providing services for people with disabilities. So this was passed in 1963. Let that year sink in. What else happened in 1963? John F. Kennedy was assassinated. So John F. Kennedy was the strongest proponent of this act. So it was passed, and then John F. Kennedy was assassinated. And shortly thereafter, a few years after 1963, in the late 1960s, the U.S. entered the Vietnam War. So because of these two events, there was not enough funding to actually fully fund the community mental health centers. So only half of the proposed mental health centers were actually built, and none of them were fully funded. So what happened is they started closing state psychiatric hospitals. So they are closing the institutions, releasing individuals back to the community, but there was no mental health treatment or very limited mental health treatment actually available in the communities. So since I believe since 1990, this has just continued to happen. So between 1990 and 2020, 90% of the beds at state hospitals have been cut. And instead, these individuals with sometimes severe mental illness were simply released back into the community without any link to actually receive assistance. So these individuals are being released. If they are on different medication for their mental illness, they're released and not getting that assistance at home to actually follow through on keeping up with their medication, keeping up with counseling, helping them kind of fully function. So as a result, that has led us into a period of time called TransInstitutionalization. So TransInstitutionalization is the period that we're currently in. So trans across, this is the idea that people with mental illness are still being institutionalized, just not in state psychiatric hospitals. The institutionalization has merely shifted from state psychiatric hospitals to other institutions such as prisons, homeless shelters, and emergency rooms and other hospitals. And this exists because individuals, when they're released back to their communities, they don't receive that follow-up care, and they might be connected with mental health issues or mental health services when they go to a hospital, or they end up in homeless shelters because they don't have family to assist them, or maybe they end up in prison because maybe they commit a crime or have a serious problem that causes them to end up in prison in some other way. But these other institutions don't have the same mental health support systems as community mental health centers. So you can see from these statistics that there's a high number of people in jails who have serious mental illness, far greater than the general US population. So 15% of men in jail, 31% of women in jail have a serious mental illness. And remember that only 1 in 25 Americans have a serious mental illness, but the numbers are much higher for the incarcerated population. And they don't receive the mental health care that they need in prison. 45% of chronically homeless individuals are also mentally ill. So they might frequently find themselves living on the streets. So again, they've left state psychiatric hospitals. A lot of those beds are no longer available, but instead, now they're simply living in other inhumane conditions, such as in jails or in homeless shelters. Or they're attempting to receive mental health care through emergency rooms. So to address the problems of TransInstitutionalization, to try to provide additional mental health treatment, several laws have been passed. One is the Mental Health Parity Act of 1996. So this requires insurance plans to cover mental health services at the same rate as medical and surgical services. So now individuals with health insurance have increased access to mental health treatment. So if you think about some of those services that are provided in community mental health centers, such as attendant care or access to medication or counseling, those are now kind of required components of health insurance plans. So health insurance providers have to provide those services now. They have to be covered. And as a result of the Affordable Care Act, more individuals with mental illness actually have access to health insurance, which is extremely positive. So because of the Affordable Care Act in making healthcare more affordable, expanding Medicaid to lower income adults, and kind of requiring insurance plans to cover more services, there's improved access to health insurance, and there's more coverage for mental health services, specifically among individuals with mental illness. So the Affordable Care Act has been very successful in getting treatment to individuals with mental health conditions. So that has been really positive. But there's always more that needs to be done. The first thing is there just needs to be greater funding for community mental health centers. So right now, Kansas has 26 community mental health centers, which we'll look at on a map on the next slide. And those are located throughout the community. But they are still underfunded. So they have waiting lists. So you can't, you don't necessarily get same day services unless you have a really, really high level of care that you need. So there needs to be more services in place for mental health case managers to connect individuals with mental illness, therapists, counselors, psychiatrists located within the community and located in all communities. Supported housing and employment services. So because we're still finding individuals with mental illness, there's really high rates of unemployment of individuals with mental illness living in homeless shelters. So there needs to be housing with individuals staff assisting individuals at home to take their medication, to help them on the job, to help with other self-care activities. Because we're also seeing increased individuals with mental illness in prisons, having training for first responders to de-escalate mental health crises. There's been several highly publicized cases of situations where someone with mental illness was killed by police officers because police don't always receive the training to assist individuals with mental illness. But there has been increased efforts to provide certain training. It's called CIT training, so it's crisis intervention training. So now there are specific police officers who receive extensive mental health training to de-escalate those situations. But these police officers are not available in all communities. So especially more rural areas don't have the funding and the police to ensure that one person is always available to address mental health issues. There also needs to be greater funding for long-term psychiatric hospitals. It can be really challenging for individuals to actually get a bed in a state psychiatric hospital. A lot of those are reserved for, again, individuals with high need and specifically individuals who have entered the criminal justice system. So it's hard to get room. In one of the Kansas state psychiatric hospitals, they don't take voluntary clients, so they only take involuntary clients who are entering the system through emergency rooms or the criminal justice system. So again, we're kind of not having that preventative care to prevent individuals from entering these systems in the first place. So we need to make sure that individuals who have serious mental illness have a safety net in place. So if they're not able to live at home on their own, there needs to be other supports kind of stepping in to support them. So specifically, if we look in the state of Kansas, again, there are 26 community mental health centers. Each number on this map represents the location of a community mental health center. The full list of the names of these community mental health centers are in the comment section of the PowerPoint slides. What you can see looking at this map is these are not evenly dispersed geographically. So if you cut Kansas in quarters, there's one mental health center for all of Northwest Kansas. Because it is a highly rural area, there's just certain parts of Kansas where you're going to be driving 3 hours just to get to a community mental health center. So there's just a really lack of access in certain parts of Kansas, and specifically in Western Kansas. You can see all of Western Kansas only has 4 mental health centers. So they're not evenly distributed. There's a lack of psychiatrists, counselors, social workers that are available specifically in rural areas. So these are considered mental health shortage areas. There's just not enough treatment. So mental health resources. So the amount of money that we're spending on mental health services has been increasing, but it's not increasing at the same rate as we're increasing because healthcare in general has been increasing. So we're not spending as much on mental health care compared to physical health. So we need to up the amount of funding and fully fund these community mental health services to enable all individuals to be successful and to have less serious impairment to their daily functioning.